with me to share with you, but this is a Friday afternoon case of a 52-year-old male who presents with a detachment. He's myope with a weak history of loss of central vision, has a giant retinal tear, and I discussed with my fellow, what should we do? Vitrectomy? Should we take the lens out? Um, and I thought that it would probably need oil. वीडियो प्ले करनी है. Thank you. So I started recording after the posterior capsular had ruptured. This was a clear lens. You know, there are cases where you decide that you would not do the phaco, or there are cases where you would always want to do a combined. This was in the middle. So I asked my fellow, he said, sir, take the lens out. Well, okay, fine, let's do it. And I ended up rupturing the capsule. But terribly disappointed. I had planned to use oil in, and I did not like oil touching the cornea. Anyway, so went back in. The eye was left aphakic and PFCL, giant tear, the usual surgery, clearing the anterior frill. And so the question is really, what should be the threshold for taking the lenses out in combined cases of detachment? It follows on from our discussion with Dr. Tariq Khan in the morning session. Should the lenses be removed in most cases of detachments? And I know practices do vary from surgeon to surgeon. I think I thought let's look at some evidence here. So in this particular case, my preferred technique would have been to do silicone oil, leave the eye phakic, and deal with cataract afterwards when I took the oil out. But as I had ruptured the capsule, I did not want to put the oil in. Wonder whether any audience would have done differently. But I have a good friend called Denzeron 68, and I used that in this case just to tamponade the retina. And this patient, whom I could not trust to position face down or correctly in the supine position, it will tamponade the retina. So this is PFCL Denzeron direct exchange, no air used, just to avoid retinal slippage. I believe you can do under air, but I prefer not to do under air. Anyway, so this was the end of the case with Denzeron sitting at the back, aphakic eye, and we went back in only about, I think, 2 weeks ago to take the Denzeron out, and retina looked fine, and we left some air in. This was the end of the procedure. So I thought, let's look at some evidence. What is the right thing to do? Should we be taking lenses out, or rather, I'll just fast forward that. There's nothing special here. So this is the 2 weeks ago. Denzeron is out, and we're putting secondary lens in. I normally use Artisan, but sometimes use scleral fixation. So this patient ended up having an unnecessary anterior chamber lens as a result of a bad surgeon. Okay. I think no matter how confident we feel about being a good phaco surgeon, but when things go wrong, it can change your game plan. Okay, so there are actually 3 big studies. First one is, I think, worth looking into the evidence on combined cases and what's the outcome data. This is a large meta-analysis of looking at more than 5,000 articles, 1 randomized trial, 14 comparative studies, looking at 2,358 eyes. It's a big, big study. And this looks at all kind of vitrectomies, including macro holes, diabetics, and detachments. What is the bottom line? Bottom line is that very interesting, primary anatomic success is better in vitrectomy-only eyes, according to this study. Interesting. Macro hole failure rate is greater if you do vitrectomy only. So that's the only one that suggests that if you do vitrectomy only, you end up having more open holes. With regards to complications, there is no statistically significant difference between combined or a separate. Posterior capsular tear, the study suggests that the difference, although seems 2.85% to 5, it's statistically significant. You rupture more capsules if you're doing separate cases. Cataract in a vitrectomized eyes, probably not all of them end up having a VR surgeon doing them. This is another head-on study on retinal detachments, 266 eyes, looking at outcomes on retinal reattachment rate and visual acuity in combined versus vitrectomy only study. And what it shows you that the posterior capsular rupture is probably the same. There's no real difference in the anatomical success or visual acuity outcomes. Another large study on detachments with phakic, doing phaco at the same time or a delayed phaco. Now, what is the take-home message here is that if you look at the p-values, there's no real convincing evidence that there is any difference in the visual outcomes. So published evidence doesn't support that doing separate operations has any benefit in terms of reducing complications, visual outcome, or retinal reattachments. But the real life, the real world experience may be different. If I ruptured a capsule, should I not worry and say, well, it doesn't matter, patient still will get good vision, but it does change the game plan. And I think it's important that surgeons should be well equipped with eventualities, maybe have alternative tamponade plans if things go wrong. Any comments?
So, first question, when the posterior capsule is ruptured and you have such a nice, beautiful anterior capsular exit, could you not have considered a sulcus IOL with capsule capturing, and that would have seen your potential oil leakage to the front?
I wasn't sure if that will hold the oil back. In the supine position, oil will migrate around the IOL to the front of the eye. I hate oil-related keratopathy, and I'm sure it's not something like.
So, but you use Densiron, which is heavy oil.
Yeah.
So that would still have maybe stayed back. Okay. In the other case, well, I've done a few of them, and I think if the capsule capture is reasonable enough, then it doesn't leak forward most of the time. Maybe a very small bubble, a very small leakage, which is lying at the top, that can be taken out at the time. And when you are using Densiron, what is the time limit that you keep in your mind to remove it?
I have a talk on Densiron later today, but the manufacturer recommendations are within 3 months. But we've had cases we've left it for much longer with good outcome.
Okay, because here I've come across a few of them left. I saw them, I didn't put Densiron in there, they were pulled elsewhere. 6 months or 7 months, one over a year. And optic nerve became pale and retinal function was not very good. So I think that 2 to 3 months is good.
Recommended is 10 weeks because it's fluorinated oil. And that fluorine is highly toxic for photoreceptors. So I think 10 weeks is the recommended.
Densiron Extra is coming out now, which they recommend you can leave it for longer.
So, but as far as giant tears are concerned, yes, I think your instincts were not to go for the lens, perhaps? Not to go for the cataract?
I would have not removed the cataract. Yeah.
Because giant tear alone is not an indication.
Yeah.
In a myopic eye, you still have a lot of space to deal with that. But
as I said, there are some cases where you think, well, let's do it. Maybe on a different day, I wouldn't have done it. So,
Okay,
Anyway, thank you.
just a minute.
Okay, so thank you very much. I just had two comments, quick comments. We've been using, I've been using Denso. Not a lot of people are using actually Denso, which is a heavy silicon oil. But we realize the emulsification rate is so high with Denso, so we removed it after 1 month. That's one thing. The other thing is, just a question. I mean, why did we use the Iris claw lens? Although you had a very nice capsule of support, reminiscent of the capsule was there, fibrosed and ready to put the lens in the situs.
I think there was a rectus missing on one side. Later on, it was noted. I might have buggered it at some point. Dendron, I present Dendron UK study, multi-center data, 7 centers, 134 eyes this afternoon. Yeah.
You know, it's a very nice presentation, Manzar. This applies to adults. You know, the feeling, I do a lot of pediatric and ROPs. So, and I use Densiron and Densiron Extra as well in complicated cases. So in stage 4 and 5A, where we have an open funnel detachment, I try to preserve the lens as much as possible. And there is so many ways to rupture the capsule in pediatric eyes. You know, the infusion slips over, indentation brings the capsule to the probe. So the feeling is the prognosis for retina, if you don't do break, is much better if you keep the lens for the month and then you can remove it with the Densiron at the time, in a month time, or 3 months time.
I agree, Haq, and younger lenses are far more forgiving to oil. You know we can oil young retinas and take it out in 6 to 8 weeks. And lenses remain clear for incredibly long period of time.
And I think the chances of PCR is higher in vitrectomized eye. If we can change the sequence, if we go for phacoemulsification in the beginning, I think we can avoid PCR and we can optimize our surgical outcome.
This is true, but my point is that if PCR rupture occurs while you're dealing with the detachment, it has more bearing on your surgical technique and what temporal art you're going to use. Having a PCR in a vitrectomized eye, again, not desirable, probably more easier to fish out the drop nucleus.
Thank you very much for the excellent presentation.
Thank you, Dr. Manzar. Actually, routine removing the lens or leaving the lens will always be a matter of debate. Every technique has its own potential of complications. Now let me invite Dr. Nesrine Abrouche from Tunisia to talk about the management of retained lens fragments or dropped nucleus.
Next. Okay. The video. Thank you. First of all, I would like to thank Professor Hossein for the kind invitation. I'm very honored to be with you today. So I would like to talk about the management of retained lens fragment and dropped nucleus. As you know, the retained lens fragment or dropped nucleus is a severe complication of cataract surgery. Its incidence is about 0.3 to 1.1%, and it can lead to potential vision-threatening complications like severe inflammation, increase in intraocular pressure, macular edema, and even retinal detachment. However, there is no defined guidelines for the surgical management of this complication or the optimal timing of surgery. So when a complication and dropped lens is happened during cataract surgery, the role of anterior segment surgeon is to do just as much surgery as is indicated, but no more. The goal of the surgery is to complete the anterior nuclear and lens removal, cortical lens removal, to clear the vitreous from the anterior chamber and wound site, if possible to put a posterior chamber IOL to suture the wounds, and a prompt referral of the patient to VR surgeon for fundus examination and planning the vitrectomy. So The dilemma between early and late vitrectomy in the setting of retained lens fragment is continue, and there is no consensus about the optimal timing of surgery. So early vitrectomy or immediate vitrectomy defined by 1 week after the cataract surgery has its advantages with reduced inflammation, a prompt improvement in visual acuity with reduced secondary glaucoma. However, late vitrectomy also may be advantages with an improving corneal clarity and inflammation, the wound healing, which will be facilitate the subsequent vitrectomy, and even in a subset of patients, spontaneous resorption of lens material may occur. However, recent studies have shown there is no predictive of good visual outcome difference between early and delayed vitrectomy, and a delayed vitrectomy after 30 days may increase the risk of retinal detachment. So in practice, when there is a soft cortical fragment in the vitreous, it may be managed with medical eye drops, corticosteroid and IOP lowering drops if there is hypertension. Large nuclear fragment and with a clear cornea may be managed with early vitrectomy as soon as possible. However, when there is corneal edema, the vitrectomy is delayed, but also it is done within the 3 weeks. So the surgical approach may vary depending on the size, the hardness of the nuclear fragment, the preference of the surgeon, and also the available instrumentation. The principle of the surgery is to do a complete vitrectomy to ensure the posterior vitreous detachment, to do a peripheral scleral depression to check for peripheral retina or remnant nuclear fragment, and also to do IOL implantation if the patient is aphakic. So in this case, with a small and soft nuclear fragment, it's dealt with 23 gauge vitrectomy. After posterior vitrectomy and posterior vitreous detachment, the lens is aspirated, or the fragment nuclear lens is aspirated with high aspiration rate to the midvitreous, where it's safer to work, and then it is removed with the cutter back on, and we aspirate the fragment one by one in the midvitreous, where it is safer to work. We can use high rate of aspiration to lift the lens fragment from the retinal surface, then we remove it with the cutter on the midvitreous. The last fragment is aspirated in the same way, and we use the light pipe to mash the lens fragment into the cutter. In the end, we do peripheral surgery and scleral depression to search for retinal tear. In this case, it's a post-traumatic lens dislocation, and it was a soft lens in a young patient. So we did it with 23 gauge vitrectomy. After posterior vitreous detachment, central vitrectomy, we aspirate the whole nucleus with the probe. We fragment the nucleus using the light pipe into a small and multiple pieces, and then we aspirate the pieces one by one with the probe with the high rate of aspiration and no cut. The cut is off. Then we aspirate the different pieces of the lens. At the end, we search for a remnant nuclear fragment, and in this patient who was aphakic, we proceed to intrascleral fixation of a 3-piece IOL using a 25 gauge needle, 2 millimeter behind the lumbus. We inject the 3-piece IOL, and we use a 23 gauge retinal forceps to put the haptics into the lumen of the 25 gauge needle, and then we cauterize the haptics and we bury them under the conjunctiva. So, in case of a large or dense nuclear fragment, If the patient is aphakic, we can deal with floating the nucleus, the whole nucleus in the anterior chamber using PFCL, or using the catheter. We aspirate the nucleus after the complete vitrectomy and the posterior vitreous detachment, and we remove the whole nucleus from the vitreous to the anterior chamber. We put it in the anterior chamber, and we can extract the whole nucleus using a corneal incision, like in the video on the left side, or using a scleral incision, like the video on the left side. And at the end of the surgery, we can put an iris claw incision. Here I'm using a Snellen loop to extract the whole nucleus, because it was a hard nucleus, and we finish by putting an iris claw, posteriorly fixated iris claw IOL. In the same, in the left video, we put an iris claw IOL, and we finish the surgery. So what if the patient is already implanted and there is a large or dense nuclear fragment? So we have to emulsify the fragment into the vitreous cavity using fragmatome or phacoemulsification. If the fragmatome, the 20 gauge fragmatome is the conventional method, but if we have not the fragmatome, we can use the standard phacoemulsification. There is no significant difference between in the size and the diameter of the two types. And in this case, I haven't fragmatome, so I do the vitrectomy, 23 gauge vitrectomy. I aspirate the lens using the catheter probe. Then I enlarge with the MVR blade the sclerotomy. And I use the phaco type with the void of the sleeve to phacoemulsify the nucleus behind the IOL, and I use the left hand to support the nucleus with the light pipe to support the nucleus, and we have to irrigate the sclerotomy to avoid burn of the scleral burn wound in the phaco type. Using scleral depression to search a remnant nuclear fragment, and the patient was already implanted. And this is the postoperative photograph. So to conclude, in front of retained lens fragment, it is a small or soft fragment, use 23 gauge vitrectomy. If it is large, dense fragment, and the patient is aphakic, you can extract through anterior chamber. And if it is a hard fragment with IOL inserted, we can use fragmatoma or phacoemulsification in the vitreous. And I think the surgeon's best approach is that in which he has the most confidence. Thank you for your attention.
Thank you. It's such a topic we can discuss for hours and hours. Due to time constraint, we are already running short of time. Any brief comments or questions?
I'm seeing a very nice presentation. I agree with you on keeping the, if you do a fragmatome, to keep it 6 millimeters away in the mid-vitreous. And I also use the burst mode, whether in the phaco.
Burst mode.
Yes, or the pulse mode, not to induce burn with the spare. We have the 23 gauge fragmatome. And we have to remove the trocar to insert it into the vitreous to remove the nuclear fragments.
Okay, thank you for the comment.
Thank you, Nisreen. I have just a small comment. The best day to do the surgery is the same day of cataract surgery. So if there is available vitreoretinal surgeon, it is better to remove the dropped nucleus just right now.
But
I tell the residents, if you have a tear in the posterior capsule, if some small part of the nucleus goes into the vitreous,
we go with the same day.
Please push the remaining parts of the lens into the vitreous, because removing the lens matter from the anterior chamber will
is
end
risky.
by destruction of the endothelium and destruction of the remaining lens capsule, which you need to implant. So he can push everything into the vitreous. We are going to do vitrectomy, so it does not make a difference if we remove one quadrant or the whole nucleus from the vitreous. And I always tell the residents that the easiest vitrectomy is vitrectomy for retained lens matter. It is not difficult. And when you are using the fragmentome, sometimes we use the infinity machine. In this case, we use the torsional mode only, and we close the intelligent phaco mode because it pushes the lens away from the tip of the needle. So we need only the torsional mode. It will hold the nucleus and emulsify it quickly after that. The most important thing in emulsifying the nucleus down, don't touch the lens unless you remove the whole vitreous and detach the posterior hyaloid. After you finish with the vitreous and the posterior hyaloid, now you can't deal with the lens matter, because if you make a lot of traction while the vitreous is still present, most probably will cause large retinal breaks. Thank you very much.
Thank you for the
As
comments.
we all know, prophylaxis is better than cure. Whenever you feel you are going to make a mistake, it's better to convert into extra capsule cataract extraction.
I have a question to Sir yourself about the duration of vitrectomy to the treatment drop nucleus. If you plan to do the same day, what would be your recommendation for the lens implantation? Sometimes it's not possible to have the lens available, say the capsule is completely gone, unless you have a bank of alternative lenses available. Or would you rather leave the eye aphakic for secondary IOL later?
Excuse me, repeat again, please.
You mentioned it's preferred to do vitrectomy on the same day as the drop nucleus. Would you put the implant on the same day, or sometimes it's not possible to have the lens that you want?
Usually we implant in the same surgery. Usually we implant in the same surgery. If there is no capsule, we adopt the Yamani technique, like what Dr. Nisreen beautifully showed. This will solve the problem, because there will be a political problem with the patients and his relatives after that. So we have to finish the job. And in most of the cases, we end with 6-6 vision. 6-6 vision is exactly as if there is no complication happen. The troubles come when we emulsify in the anterior segment, where we injure the endothelium, injure the iris, injure the remaining capsule. So it is better to emulsify in the vitreous. It is more difficult, but it has a better outcome. Now let me thank you, Doctor.
Thank you for the nice presentation.
Now Professor Ihab Othman from Egypt will talk about double rectangular scleral mesh for severely subluxated or dislocated IOLs, a closed vitrectomy approach. This is a brilliant idea. Let's concentrate on what he's going to do.
Thank you, Dr. Tariq. Thank you for the ASCO for the invitation. We're really enjoying the warmth of the hospitality and the generosity of our presence among you. I might answer my dear friend's question, Dr. Manzar Saeed, about what to do if we have the problem of IOL, even if it's dropped out in absence of a capsule. So there is no doubt that the posterior chamber placed IOL is the best location, even in the absence of a capsular support. The described techniques talk always about haptic fixation. So every described technique in the literature always talk about doing something with the haptics. Nobody thought about doing something with the optic to fix the optic into the global wall. And there are always complications. So the technique we're describing today, and we've been doing this since 2009, depends on fashioning transclearly at 1.5 millimeter from the limbus, a double rectangular mesh. This mesh holds and supports the IOL optic. We tether the IOL optic within, and we provide a cushion for IOL fixation. So the idea is to go 1.5 millimeter from the limbus, from point A to point B using the long 9-0 or 10-0 Prolene suture. We go transclearly after doing a radial conjunctival periotomy, and we exit at 4 millimeter apart. So the here the limb is from A to B is 4 millimeter at 1.5 millimeter from the limbus. We go back transocular from point B to point C. We exit at 1.5 millimeter from the limbus. We feed the needle into a 27 gauge tip, and then from C to D transclearly 4 millimeter limb, and go back at point A where we do a temporary knot. So this is one rectangle that is formed within the eye. The other rectangle is formed similarly, E, F, G, H, and the knot at E one more time. And I will show you with the surgery how this is done. Can you skip? No. Next. Yeah, I'm trying. So the scleral mesh is fashioned to hold the IOL, and the IOL is put in position. This is an example of how it looks like at UBM, and you can see the underneath scleral mesh, and the optic is tethered within. This is another picture of how it looks like on a post-operative follow-up. We use this in several ways and in several techniques. This is a patient with microspherophakia and what seemed to be an aniridia. So the lens is totally taken. There is no point here or use of leaving capsule. And then we go 4 millimeter on each quadrant. We here at the entry point fashion a 1 millimeter scleral flap with a scleral blade knife. We exit 4 millimeter, come back, and then go here. Once we go out, we go transscleral. As you can see, we don't do any scleral flaps or anything like that. We exit and then come back at the point. Here we do a stay suture, and then come back here on the opposite quadrants. And as you see, we can tether the loops within. You know, we go from one side on top and one side beneath to have a tethering effect of the double rectangular scleral mesh. Get out, transscleral, and then come back. As you can see here, one above and one below, so that the loops will be tethered together. So here there is absolutely no scleral support. We put the sulcus fixated 3-piece IOL, and we fix the optic within the limbs of the rectangular mesh as if it was a capsule fixation. And we're done with the surgery. We're stretching the iris. The patient was not aniridic and he could function. This was the only eye of that young patient with osteogenesis imperfecta. So this is a situation where we have a dislocated IOL, and we do the same. And I'm pointing here that we have to release the IOL from all the vitreous attachment. And after fashioning the scleral flap, we can just implant the IOL in a closed vitrectomy system, which is really important. We don't have to explant and do all the techniques that are described until very recently into the literature. So the rectangular mesh is fashioned before doing the vitrectomy, and then we just go and pick up the IOL and put it in position and tether it in place into the newly manufactured sulcus. I'm pointing here to a very important issue that Dr. Nisreen mentioned. We really have to clean up the posterior segment. And not only that, we have to look at the periphery for a retinal break. This is a retinal break coming from the previous surgery and the complication of the previous surgery. And we really have to do the deep scleral implant indentation and look thoroughly at the periphery, because if we leave this in a week time, we'll have a recurrent we have a new onset detachment, and everybody will be pointing at the last surgeon who did the surgery. So this is to complete our surgery here. We do have to examine the periphery, and fluid air was just enough to finish up with the surgery. The double rectangular scleral mesh is used now for keeping the silicone in the posterior segment if we don't have enough iris. And this is a technique that is described in the literature. And also, at the time of silicone removal, we can implant on the scleral mesh once it is fashioned and the silicone is out. And as you can see, the optic is very much positioned and tethered within the edges of the mesh as if it was an anterior capsule. Now we're thinking further to even suture the iris into the mesh if we have a large iris defect. This is another more useful tool. If you don't enough iris tissue to bring the iris together, we can suture the iris to a very far away point on the two sides, and this might help a lot in just re-establishing the anterior iris diaphragm. Well, what about the stability? You know, this was an aphakic patient that came 10 years later with secondary glaucoma. The aphakic patient had a double rectangular scleral mesh 10 years ago, and she's coming with secondary glaucoma. So as anybody, if you was really concerned about the stability of the mesh, we used at the time 10-0 nylon sutures. And you can see we are maneuvering for a subscleral trabeculectomy with a big stability of the IOL, and we can even maneuver the IOL if it was a little bit displaced during the hypotony induced by the glaucoma surgery. So it's very much stable on a long-term follow-up, and it can do the optical rehabilitation as we wish. Another indication is the subluxations, and we can use one limb on the defective support side. This is a patient that I previously performed vitrectomy, phaco-vitrectomy on her years back, and she got punched by her grandson in the eye, and she is coming with this severely subluxated in the bag IOL held by few zonular fibers on the nasal side. And this was quite a challenging case because here we have the IOL in the bag and it's really free floating while the patient is lying supine. So, you know, we have alternatives to remove the bag, to remove the IOL and do extra major surgeries. I decided to use the experience gained by the double rectangular scleral mesh over the years and see if I can help. And this is the very critical moment where you have the coronary spasm, you hold your breath and try to flip it over and pass it over, and now you can breathe. So we could put the IOL back in position, and this was a very stressful issue that you can put back. You have at least one limb and then do the routine you used to do in a more comfortable situation. And the double rectangular mesh from one side was quite useful in reassuring the surgeon, that is me, that I will have I have to finish a successful surgery. The IOL was not centered because of the fibrosis happening into the capsular bag. So I had to remove the capsule and the summering ring very carefully, because also we don't need to bite the Prolene
that will definitely break, and then we have to redo our mesh. So we use every technique from the anterior aspect, posterior aspect to remove the submarine ring, residual capsular bag, and capsular bag remnant, and then we tether
Can you
the
please
optic. Yeah, I'm finishing
wind
up,
up
sir.
it quickly with time constraint?
Yes, sir. I'm done. Voila. We review the vitreous. Everything is fine. So this was the position, very well-centered position. So we have a big advantage of placing the IOL in a closed system. We don't violate the conjunctiva for further surgery. There is no scleral flap necessary. Definitely placement in anaeridic patient, silicone oil-filled eye, subluxated IOL. We did our publication back in the years. I would like to invite you to our meeting on February 16th and 17th. It will be held in a very nice, luxurious palace in Egypt, Abdin. And the theme is what's next? What's next if you got stuck with any of our problems and our issue? We'll have a disguised mask party in the evening of the Thursday, and definitely would love to have you all in Egypt. Thank you very much.
Thank you, Dr. Abad, for showing your innovative technique. Our next speaker is Dr. Amir Awan. He will talk about outcome of autologous inner limiting membrane transplant in failed and recurrent macular hole. Dr. Amir Awan.
Good morning, Assalamu alaikum. It's not coming up there. Okay, that's fine. Okay. So we know that ILM peeling is really important for certain retinal disorders like macular hole, vitreomacular traction, retinoschisis, or ERMs, and it provides basically complete relaxation of any traction over the macular area, and again it prevents the risk of post-operative ERM formation. But however, we also know that in refractory macular hole, just removing ILM doesn't help. So we come across these cases. And different things have been tried, like light silicone oil, heavy silicone oil, blood derivatives, either partial or complete, or to fill in or along with some other procedure or just alone. Or autologous tissue is used like retinal graft, lens capsule, anterior and posterior, or ILM flap can be used. And the rationale being that it acts as a scaffold, and over that the macular hole gets closed. And so failed macular holes or reopened macular holes, which happens very rarely, so mostly are the failed macular holes. So 7 patients, 5 males and 2 females, mean age was 46.5 years. So that's basically the base diameter, 821 to 1721 microns, and idiopathic macular holes, 4 were idiopathic macular holes who failed. Post-retinal detachment surgery, 2 macular holes, and 1 was traumatic macular hole. So these all are vitrectomized eye. So 27 gauge 3 ports pars plane vitrectomy system we used from the Alcon, and autologous ILM transplantation was done. So I'll show the videos. So this is a traumatic macular hole, the large one. So I'm using the dye to stain the capsules. Here you can see already ILM peel is done. I'm slightly enlarging it. And then planning to use a part of this ILM and just put it in the macular hole area so that it stays in. It doesn't come out of that, because if you leave it at the top, it's going to just dislodge. So you just need to put it in the whole area. So infusion at this time is at lower. So I'm using 20 millimeter of mercury. And you can use your light pipe again as well to help as a second instrument, and that can help to put it in. So you don't want to put multiple layers, so just a few layers and trim the remaining one, but be careful, it can just come out if you put it. So once it's put in, important thing is the fluid exchange. You don't want to remove the fluid from the macular hole area, because in that case the flap will just come out. So go at the disc, do fluid exchange, try to do as complete as possible. And then C2F6 gas was injected in isovolumetric concentration, and patient was asked through posture for a day, and next day OCT. If a hole is closed, no further posturing, they can sit normally, no face down they need to do, but they can sleep on the opposite side. So just the next movie, that is basically the patient who had failed macular hole surgeries. I wasn't sure ILM peel was done or not. So here basically ILM peel was not done. So I'm doing ILM peel and I'm going to leave slightly attached ILM along the whole area. So it's a very large hole. So that's why I decided to put the flap there. And you need to do a large ILM peel in such cases because you don't want any traction to be remaining. Sometimes if you feel that ILM flap can move over, you can put viscoelastic at the top of that to keep it in. So here I'm placing it in. And once it's done, we'll do fluid exchange similarly and finish up the case. So here it's sitting in nicely. So I'll move to my last case. So this is post-retinal detachment surgery. It's a large macular hole. Patient was disappointed. Retina was picked by distortion. So I'm using the dye. Surgery was done somewhere else. And the patient already had ILM peel, you can see. So I'm enlarging it. In this case, there was temporal retinal detachment as well. So there was a large break which was still open. So I'm peeling the ILM and then going to put in. So here, basically, I'm going to do the more maneuvering, indenting and things. So I'm going to put PFCL at the top and properly locate it in the whole area so that it doesn't dislodge. So you can put heavy liquid earlier as well, and then you can put the flap into there, but I have already put in, and just shortly you would see me putting the heavy liquid to keep it in, and I'll just adjust it accordingly. So I'll just move forward a bit. So here, basically, I'm just making sure that it's in there and then a heavy liquid coming in. I'm just placing it over and to finish the case by doing laser to the retinal break area. Again, C2F6 tamponade was used in this case. And the patient was asked to posture, and next day I did OCT. And if the hole is closed, and even in this case it was closed, no further face down posturing. They can sit normally. Only thing is sleep on the opposite side. Sorry, can you move to next slide? Can we go to next slide? Okay, so go. Okay, so face down posturing already mentioned. So type 1 macular hole closure achieved in all cases. 6 patients had improvement of the vision from 615 to 618. 1 patient had 6/60 vision. That was the patient who had a retinal detachment previously, but that again improved from the counter finger vision to that level. So there are a few examples I'm showing here. So this is the lady basically with failed macular hole surgery, and it's closed now. You can see there. This is the traumatic macular hole, large retina hole, and that again is closed after the surgery. And this is the guy with the post-RD macular hole, and that again closed nicely, and patient improved the vision to some extent. So I think refractory macular holes shouldn't be left. They need to have another try and try to close them. And ILM transplant is a simple and effective technique. Thank you very much.
Thank you, Amir, for finishing your presentation within the time limit. Our next speaker is Dr. Tariq Khan. Is he around? Okay. Dr. Tariq, artificial intelligence? No, it's the most promising technology in future. Dr. Tariq Marwat, I think, will talk about it. Artificial intelligence in retina.
Thank you, Dr. Tayyab. Artificial intelligence is a relatively new technology, especially for ophthalmologists, although it's in use for more than a decade in other specialties of medicine. Basically, what artificial intelligence is, that these are the technologies in which the computer is performing the intelligent functions, and they are actually acting and behaving like humans. But they always need human intelligence for the pre-feed. there are different subsets of artificial intelligence, and one is machine learning. These terms are relatively new for in our profession, so I'm going through it. Machine learning is when machines are evaluating and learning from data, and then subsequently they are performing tasks to classify that data and then draw a reference, then draw a conclusion. Machine learning technologies, generally, they do not need human intelligence for their function. There is another term which is deep learning. Deep learning is basically a type of machine learning in which a platform or an algorithm is being made, and it is then used to classify the data, and then an artificial neural network is made which can work intelligently without human intervention. The examples of deep learning is the DeepMind, which is well known in Europe. There are different subjects being dealt with this type of platform. Also, there is an NHS project to classify and screen diabetic retinopathy. And one other is Power9, which has extensively been used in India for mass screening of diabetic retinopathy. One other thing is cognitive computing, where the computers are capable of thinking, reasoning, and remembering, and thus making decisions. Cognitive computing is the base of artificial intelligence technology for the surgical use in retina. Although it's widely being used in other specialties, but in retina it's relatively new. For all these subsets to work, the crucial thing is the data science, in which we feed data to the computers, and then different platforms actually analyze that data and come up with intelligence. These machines can speak, they can see, and they can talk just like humans. The difference between the human intelligence and the artificial intelligence is the perception. Human intelligence is based on perception and then experience, while artificial intelligence is based on those data sets which are being fed to them, and then they come up with an algorithm to perform a specific function. Superintelligence is the combination of artificial intelligence and the human intelligence. How artificial intelligence is impacting our lives. The recent James Webb Space Telescope is one of the examples, which is actually showing the boundaries of the universe, first time in human history. Another example is the driverless cars. This technology is actually based on super intelligence, which is combination of artificial intelligence and human intelligence. This was the first machine which was practically used to deal patients for laparoscopic surgeries, and this is based on artificial intelligence. It actually, this technology saves time, it reduces chances of misdiagnosis and save on labor and cost, while the surgical side has a high precision and certainty, and the results are relatively more uniform and the outcome is definitely better. Power 9 was the first artificial intelligence project which was launched somewhere in 2009 in the field of ophthalmology, and it was practiced in different parts of US and India for screening of diabetic retinopathy. Another platform is the Google's IPAX. This is also actually a diabetic retinopathy screening platform, and it has developed an algorithm by the name of ARIA, which is now widely used in different parts of the world for screening diabetic retinopathy, especially the diabetic macular edema, and also the ARMD. The accuracy of artificial intelligence-based machines is higher than the skilled human performance. And the ARMD device actually has the accuracy of 92%. There is another platform which screens the OCT scans of ARMD and diabetic macular edema, and the accuracy is 99.9%, which is much higher than an expert retina specialist. IDX is a FDA approved device which is in use for diabetic retinopathy screening. It is based on artificial intelligence, and its sensitivity is 87 and specificity is 91%, which is higher than the expert human retina specialist. Now, actually, on the basis of retinal OCT images, the dementia is being predicted and actually diagnosed on a much earlier stage with this technology. Also, different cardiovascular risk factors can be predicted with this technology just by looking at the retinal images, and the reliability factor is 97%. Robotic retinal surgery is in the clinical trial stages now, and it is the next generation technology where the microsurgical robots will perform fully automated surgeries without the input of a surgeon. The precision of the robots is up to 1 micron, which is almost 100 times greater than a human expert surgeon. There are different machines which have been developed for the robotic retinal surgeries. They include Iris, Minutia, and Precise. Precise has already been it's in the early stages of FDA approval, and it has been tested on human eyes as well. The first machine was the Iris, which was developed at the University of California, though not ever used on human eyes yet, but it is in the process of developing. The other machine, Minutia, was being developed at Belgium, but Precise, which was developed at Oxford, is the first commercially available intraocular robotic surgical system. And actually it is used for very minute, very fine surgical steps like ILM peeling. So, although still an aid to human intelligence, and artificial intelligence technology is still not a replacement. It has emerged a major frontier in healthcare. There is a wide scope of artificial intelligence in diagnosis and management of retinal diseases. And the new technologies in this specialty are the robotic automation, the virtual reality, and augmented reality. Thank you very much.
Thank you, Dr. Tariq, for presenting this fascinating aspect of the artificial intelligence. I think the only problem is the tactile sensation. They are working on it very hard. Anyhow, thank you very much. Our next speaker is Dr. Mir Ali Shah. The title is Treatment of Kissing Choroids.
वीडियो को फास्ट चलाएगा वीडियो को बिस्मिल्लाह रहमान रहीम कहाँ है There is a case report of kissing choroidal or hemorrhagic choroidal detachment. And to get your feedback, how many of the participants have seen the full appositional, complete appositional, non-dissolving choroidal hemorrhage? How many of us have seen it? Okay, thank you. And how many have intervened in this case? Any drainage? Thank you. So at the end, we would like to have your feedback. कहाँ चेंज होता है जी Okay. We will discuss the B scan of the choroidal detachment. We'll plan a drainage. We'll search the literature, and I will present a video. So this is the kissing choroidals on one side, and from the other side they meet in the center. The patient is a 75-year-old, has the only eye. The other eye has already been lost due to glaucoma, was no perception of light. And this patient had a combo surgery of trabeculectomy along with cataract and IOL 1 month ago. The vision in this eye was just perception of light. And in the 4 to 5 weeks, the vision did not improve. Pre-op record shows he was a referred patient. The pre-op record shows the 6/18 vision in that eye. And the operation record shows choroidal detachment during surgery. The eye was soft and there was no fundus view. Behind the lens, nothing was visible. We planned the surgery, and the ideal is to put an AC maintainer and dredge 8 millimeter infero in the infero-nasal quadrant. On first post-op day, the vision was improved to counting finger, and there was still a small nasal elevation. After 1 week, we could see the vision was slightly improved, but we could see the nasal and temporal small elevations. In second week, we again saw that the vision has dropped down, the intraocular pressure is low, and the small nasal and temporal elevation. At that time, we had to decide what to do. Searching the literature, we got the news that you can inject gas. So the gas was injected, and the next week the patient vision improved to 6/60, and it was corrected to 6/24. Very happy moment for us. And the IUP was 14. The nasal and temporal elevation was still there. We are still observing the patient. The pearls about this procedure is, if the Charles Mango says, if in a positional choroidal detachment, I will make the decision to drain if there is no resolution within 1 week. Another statement is that if there is considerable pain and no improvement, then drain regardless of the positional status. Even if these are not kissing choroidals and there is pain and no improvement, we should drain it. Before the surgical intervention, we should start the patient on 2 to 4 times atropine or cyclopentolate and topical steroids. Oral steroids and painkillers are also advised. If the pain is more and the patient is non-diabetic, you can use methylprednisolone. What are the indication of drainage, when we should drain? If there is detachment with retinal apposition, no fundus view. If there is angle closure with elevated intraocular pressure. In non-appositional cases, we can observe longer in hopes of spontaneous resolution. But if there is no pain, partial choroidal detachment, is if there is hypertony or other cause of the detachment, like shallow detachment, cerebral detachment from trauma, we should treat those as well. So treat the cause and let the choroidal detachment resolve itself without an attempt at drainage. If it's a chronic partial choroidal detachment, drain if no resolution, and if there is symptomatic visual defect. The literature review showed us that choroidal detachment is an unfortunate complication of ophthalmic surgery with significant ocular morbidity. Often, VR surgeons are involved in the management, but the anterior segment surgeons can do it. However, evidence to support a standardized approach to a treatment strategy is still not well established. Thomas Albini says that I found most choroidal drains, they drain well through standard anterior sclerotomies side once infusion is achieved and IOP is raised. Most of the surgeons, they advise they drain after 1 to 2 weeks. Dr. Piner advises wait for 10 days, observe closely with B-scan. Wait, this will also give you some liquefaction to occur. Use the B-scan to identify the quadrants with the most prominent choroidal where to drain. We should not go inside more than 3 millimeters. The bevel should be kept away if you are using the needle from the choroid. It's better to hook it or attach it to an active aspiration retractive machine, but it can also drain spontaneously. 9 to 10 millimeter or 8 millimeter is also advised from the limbus in the area of high choroidal detachment, usually temporal to give best access. All the choroidal detachment, they flank pretty equally from one drain site. Second drain site may be needed, and insert a 25 gauge cutter if that drainage sclerotomy site is clogged by a clot. So you have to remove the blood clot. When to combine this drainage with vitrectomy? If there is retinal detachment, if there is vitreous hemorrhage, and at that time we have to see the periphery of the retina for the breaks. Generally we use 20% SF6, but in this condition 30% SF6 gas tamponade is advised. You can make a 3 millimeter radially oriented scale cut down with a blade 8 millimeter posterior to the limbus. To get the drainage of all hemorrhage, you puncture the area with a needle to start the flow. Apply constant pressure with cotton tip applicator near the sclerotomy. This will maintain the egress of fluid. Perform a combined vitrectomy if retinal detachment is present preoperatively. Again, Dr. Prenner, he is using the technique of his teacher, Flavio Rosendi, and they use 25 gauge trocar and infusion in the anterior chamber and put it on. Place a transconjunctival 25 gauge trocar. They use 7 millimeter from the limbus in the corner of larger detachment. Place trocar at 15-degree angle for shallow, so that it remains shallow. It should not go directly. Insert the trocar to 50% of the depth, roughly 3 millimeter. Drainage is usually dramatic. Examine the eye, choose a second drain site and repeat the procedure if significant choroidal detachment persists. Vitrectomy is indicated if there is retinal detachment or vitreous hemorrhage. So this is the video of our case. We tried to put the trocar, but this was not visible in the vitreous cavity. So we did not start it on, and we will, yes, now we are trying to put the AC maintainer. So the AC maintainer is inserted. This is the infero-nasal quadrant. We are going for 8 millimeter behind the limbus. This is the trocar. This elevation was quite high, so we have intentionally put a little deeper. Otherwise, 3 millimeter is advised. The intraocular pressure is maintained, and we can see the fluid. It's coming out. The problem here was that the trabeculectomy site was also leaking. So we have to observe that. The superior nasal trabeculectomy site, the fluid is coming from that area also. Now we will look at the retina, how is the condition. We have removed that sclerotomy trocar. Another trocar is inserted. It's 23 gauge. 25 gauge is better if it's available. We are happy to see the disc for the first time. So, at this time, there was no fluid or no detachment left, but next day we had some. We removed the sclerotomy sites, sutured this, and some air was also left in the vitreous cavity. You are all welcome to the Peshawar Congress in the next February. Thank you very much.
Thank you, Dr. Mir Ali Shah. Choroidal detachment usually settle down at the end of the day, provided you address the hypertony.
Provided?
Now, you address the hypertony. It usually settles down sooner or later.
Yes, we waited for 5 weeks, and this was the only eye of that patient.
Yeah.
So there was no improvement in the 5 weeks. So that is the literature says, if no improvement for 2 weeks, you should drain it. We were not very bold to drain it in the first 2 weeks, and we didn't receive the patient in the first 2 weeks. So the hypertony, there was no leakage. The hypertony was not going to settle spontaneously, and now the patient is improving. Thank you. Any further?
Was the bleb overdraining?
What?
Was the trabecular bleb overdraining?
No, the bleb was not overdrained. In fact, this patient also had, in the meantime, before coming to us, had high IOP for some time, and he was put on acetazolamide. But when we saw hypertony, we stopped acetazolamide. So there was no overdrainage, but the bleb opened when the intraocular pressure raised during vitrectomy.
That was during
yes.
surgery. So what Dr. Tayyib just mentioned was that if the bleb was overdraining, perhaps then we could have put some sutures on that area, and that would have settled it. But if it wasn't, then it was just hypertony, and then that was the way to go.
Thank you. Any further suggestions?
Thank you.
Thank you very much.
Dr. Mir Ali Shah. Now I request Chairman of the session for the concluding remarks.
Thank you very much.
So, inshallah, we will meet at 2 p.m. for the next session. Thank you very much for your participation. Thank you.
Symposium 2. I welcome you all, and I hope with time the numbers will get a little bigger so that we can have a full detailed didactic session. I would like to introduce my colleagues in the session today, Mr. Mahmoud Al Rabia. He'll be our chairman. Welcome, Mr. Mahmoud. Mr. Babikar Haga Abdul Khair Aboshara, our co-chairman, and myself, Usman Mahmood. So I think I'm the first speaker, so I'll start. As the session suggests, is the retinal detachment. Can we start? Okay, it's not coming up here. Right, so basically we start with the vitrectomy for retinal detachment and the tamponades. It's an update. Nothing much have dramatically changed in the retinal detachment surgery. However, there are certain principles we need to adhere to. So as we all understand from as the retinal surgeons, the retinal detachment would be rhegmatogenous, tractional, or exudative. So this is the one which we come across mostly as we are surgeons, rhegmatogenous, where there is a break in the retina resulting in retinal detachment. Obviously, it can be a single tear, multiple tears, and that results in detachment which could be partial or complete. The second one is tractional. Tractional, as we understand, usually related to the vitreomacular interface problems, usually vascular diseases, diabetics, vein occlusions in the severe form, but generally advanced diabetic eye disease where the proliferation into the vitreous and the fibrous contraction results in the tractional elevation of the neurosensory retina. And this is one of the examples where it's a worst form, which is a tabletop tractional retinal detachment, the most dreaded picture as a vitreoretinal surgeon we see. And also, it can be combined because whenever there is a traction, these forces work, and the weak areas in the retina sometimes can get a hole, and you can have a combined rhegmatogenous and tractional retinal detachment, which is not very uncommon in very advanced diabetic eye disease. So what are the mechanics? We all understand that whenever there is a break in the retina, the fluid or preretinal fluid can escape behind the retina, causing the detachment of the neurosensory layer from the retinal pigment epithelium. And this is again a schematic diagram of rhegmatogenous retinal detachment as compared to the tractional and exudative. The only difference is that in the rhegmatogenous type we have a retinal break. However, in tractional and exudative type there is accumulation of fluid without any break. So this is a picture of the exudative. Usually it's uveitis related, a lot of inflammation in the choroid resulting in capillary breakdown and accumulation of fluid under the retina. It can elevate the retina, cause retinal detachment, but however it's exudative. It's very important to distinguish this from the rhegmatogenous type because the treatment is entirely different. So the purpose of the detachment surgery or treatment is to reattach the retina with the RPE so that it can regain its visual function. So what are the principles? And these are very important to keep in mind because these are the ones on which the retinal reattachment is achieved. So the principles are to remove the traction, to make room in the vitreous cavity for internal tamponade, identification and localization of the retinal breaks under direct visualization, remove all the tractional elements or address the retinal shortening, membranes which could be pre-retinal or subretinal or bands, and to remove the subretinal fluid internally. The vitrectomy systems which we are familiar with, 20 gauge, 23, 25 or 27. Most of the time nowadays 25 plus is most commonly used, and however 23 gauge is still fairly prevalent. So the principle is to begin with a core vitrectomy, which is obviously to remove the vitreous in the middle, peripheral shaving of the vitreous base, trimming over the breaks, that is vital. Amputation of the flap, I think this is vital because if you don't remove the flap, the vitreous still can cause attraction and then you can have a redetachment. And removal of the anterior retinal flap in case of GRT or large slit breaks. So this is an example of a chronic retinal detachment. You can see a lot of pigment in the vitreous, and just with the help of indentation, you can see the flap here and the frill of vitreous attached to it. So it's important to remove all this and specially amputate the flap, because until the flap is amputated, as I said, it is going to continue to have traction on the top. So it's very, very important to remove this before you complete the vitrectomy. So once it is achieved, then again, nothing can be less emphasized on internal search, which is very, very important to localize the internal break or breaks, evaluate the extent and the nature of the retinal detachment, and to evaluate the mobility of the retina. The break localization is vital, because once you start planning into the fluid-air exchange, if you're not localized and mark the break, they can be lost under the air and it will be difficult to find then. Removal of subretinal fluid, internal drainage through the break, if it is easily achievable and you think that you can remove the significant amount of fluid. If the break is little posterior, or if it is too anterior, then a retinotomy can be obviously undertaken. So in anterior breaks, small phakic, you can use the heavy liquid to drain the fluid through the retinotomy, or close and do a retinotomy close to the disc. If the large anterior breaks, you can do it through the break with the extrusion needle, and you tilt the eye to make the most dependent part. So this is again one of the videos where a retinotomy is being created just beside the optic disc. Normally I do it with the cryo needle, the internal endocautery, and with the flute needle touch it slowly to create a small opening sufficient enough to drain the fluid from there. And in that case I don't have to physically make an opening. However, the flute needle is good enough to create opening sufficient to drain the fluid from there. So it's going backwards. It's going backwards. Yeah. Can you move forward the next slide? And more. Right, if there is a bullous detachment, again this is a challenging thing. It's important to drain the SRF in the beginning to settle the retina, because if you leave it like that, there's a high chances that you can create iatrogenic breaks with your cutter. So this is one of the videos also showing this a bullous, semi-bullous detachment, and the cutter on the left side is located just at the break side when I entered into the eye and start draining the fluid straight away. And you can see that the SRF is being drained and the retina is settling down nicely, and you can see more space is being created, and then it would be quite safe to commence the normal vitrectomy. So the pearls are that we need to be patient. We need to make sure that we have a good view before the air fluid exchange. We start the air fluid exchange with the extrusion needle just above the break. And once the channel is established, then start the fluid exchange. Do not remove the fluid needle. It's very important until the fluid is completely drained. I think initially during my early training stages, I remember I used to get impatient and draw the fluid away, the fluid needle away, thinking that the fluid has been drained, but you need to be patient. And decrease the fluid air exchange to 20-25 when you start the exchange. So the treatment of the break, as we know, is endolaser or cryotherapy. Endolaser can be localized or 360-degree depending type of pathology. I'm not too keen to do 360 all the time. I just try to treat the breaks. And in very, very remote cases when there is extensive pathology in 360 degrees, multiple lattice or multiple holes, then I choose to do 360-degree laser. So when you do 360-degree laser, 3 rows of laser in the periphery, gentle whitening effect. And normally these are my settings, but obviously they change according to the pigment of the retina. Cryos, normally I keep it quite minimal and confine it to mainly phakic eyes and the peripheral breaks, or if there is a single break and phakic eye and quite anterior break, then I think cryo is a better choice than the endo laser to avoid the lens touch. So again, the important thing is that once you start seeing the reaction, don't pull it away. Just put your foot up, release the cryo, and leave it and stay there until you see that little frosting. Idea is to avoid going directly onto the break. Just cover the peripheral, because if you go directly onto the break, it will flush retinal pigment epithelium into the vitreous cavity. So avoid that. And for endo laser, basically, again, as I explained, the principle is the same. To achieve gentle whitening starting from the edge of the break going to the periphery, ideally to do it with indentation if it is peripheral. If it is not too peripheral, you can do it without indentation. So tamponades, obviously gases, silicone oils, buccals. So I won't go into the details of the volumes and everything, because I think we are all well aware of this. SF6, it is used for single to small or medium sized breaks present in the superior half of the retina. It tamponades for 2 weeks with 20% isovolumic. Fresh retinal detachment without PVR is the indication, and it's a good one to use, but in selective cases. This is the one I mostly use, and it works quite well in my hands. It's tamponade for 4 to 6 weeks, expensible at 20%, single or multiple breaks above the horizontal plane. C3F8, only I use it very rarely, however, it's 14% concentration. Multiple breaks, opposite quadrants where you need to have tamponades for a long period of time, and also the one which is slightly inferior. Silicone oil, we are all well aware of 1000, 2000, 5000 or heavy or Densiron. 1000, I'm quite happy to, mostly I use 1000 or 1500 with multiple breaks. Elderly patients who cannot posture, normally remove it in 2 to 3 months time. It gives a good persistent tamponade, however it gets emulsified, so you need to remove it. This is the one I'm quite happily to use and report that I found it quite helpful for the inferior retinal pathology, inferior breaks, where the patients are hard to posture. It works very well. It used to be a Densiron, normal Densiron, which is to be kept in the eye for 3 months, but now we have heavy Densiron or Densiron HD, which can be kept into the eye for 6 months. And I found no problems regarding pressure or emulsification, and reasonably easy to remove with a certain proper technique. So here is a quick video of removing of the Densiron. Obviously, because it's a heavy oil, so you need to keep your cannula in, keep the pressure up, the vacuum up, and as the bubble starts lifting from the surface of the retina, you reduce the vacuum and keep it as a single bubble. And the trick is not to allow this bubble to fall back, because there can be a problem. You can see a small bubble there. Sometimes you can take it, but then if there is a small bubble left down, you can go down and extrude it with the cutter, and it comes out. So this is the little trick, that you need to have high vacuum initially, and then as the bubble gets less, you reduce the vacuum. So 5000, I confine it only for very long-term tamponades in chronic retinal detachments. Can be combined with external buckling, which I really personally don't do much of it. Less chance of emulsification, but definitely don't forget to do a PI, especially inferior in aphakic eyes. Buckles, we have bands and sponges. 240 band, 276, 277, 278, we're all familiar. In my practice, less than 1%, about 1% cases I use bands or buckles if I have to. Nowadays, because of the advanced techniques, good vitrectomy systems, if you do a thorough cleaning of the vitreous, I think bands are not required. I won't go into the details of the retinal relaxing steps. I think this is important to be in the part of your armory to deal with this. After vitrectomy, you need to relieve all the tractions. You need to relieve all pre- or subretinal membranes and bands, and relaxing retinotomy if needed, or retinectomy. So this is a small video where there was a retinal shortening here. So under the air, I realized that the retina here is not settling down. It means the retina is shortened. So I proceeded with a localized retinectomy under the air. I normally create a barrier with the endodiathermy, and sometimes with a cutter or sometimes with a scissor, just do the little relaxing incision. And you can see once the traction is released, the retina starts settling in. And I found it doing under air is good because it keeps the tamponade on, and prevents any bleeding or anything. And the retina seems to be quite stable under air. So in conclusion, it's a vision saving procedure. The management starts in the clinic. This is very important. Nothing can be said against the detailed examination, including the biomicroscope examination. Indirect examination is vital, and planning of the type of procedure, type of tamponade is very, very important, and it is decided in the clinic rather than in the theater. Extra half an hour spent in the clinic and theater can give a patient miles of vision. Thank you very much.
Thanks, Dr. Osman. Thanks, Dr.
Any
Osman.
questions there?
And I would like to introduce Dr. Manzar Saeed.
I think we'll leave the questions at the end. We'll leave the questions at the end.
Okay. Thanks, Dr. Osman. I would like to introduce Dr. Manzar Saeed. He will talk about Denseron tamponade for inferior retinal detachment.
Thank you. I'm going to talk about heavy silicon oil tamponade, a multi-centered experience in the UK with 7 centers. Now this is Norfolk countryside where I work. As you see, it's very flat. On cursory look, it looks like Punjab. So it's very, very flat. But you don't always get flat retinas like that. Look at this inferior detachment, something that not all VR surgeons would enjoy doing, with sort of inferior pathology, a challenge for everybody. Usman recently showed cases of inferior detachments like this. So what do? We know gases don't work best in inferior breaks. Silicon oil, conventional, float up, and they're not good at supporting inferior pathology. Buckles is an option, but not when we're doing internal job. So what is the data on heavy silicon oils? The first generation oils came out something like 20 plus years ago, and they were fluorosilicons and perfluorocarbons, and these were associated with high risk of inflammation, cataract, macular toxicity, and even retinal necrosis. Hence, the take-up rate for first generation heavy silicon oils was not that great. Now, things have moved on. There are generally 3 types of heavy silicon oils. We have Denseron 68 by Goider, it's a German company. And then you have Ella Heavy by Alamedics, and then Oxane HD with Bosch and Lomb. Now, for all these 3, the most popular used in the UK is Denseron 68. It's a combination of silicon 5000 and perfluorohexyloctane F6H8. And it's a kind of medium range viscosity. And it was used in the heavy silicon oil study. It is published in Act Ophthalmologica in 2011. So let me share our experience of 7 centers in the UK of Denseron for inferior detachments. There were 9 centers. Number 2 center that's where I work. So it was a retrospective study. So we had 173 eyes, and those that completed the follow-up included in this final study was 134 eyes. All had inferior detachments from 4 o'clock to 8 o'clock with at least 1 or maybe more breaks. And this data spans over 5 years. Now we had primary outcomes. The primary outcome measure was reattachment at 2 weeks with the oil in situ, and then again at 3 months after Denseron removal. And the secondary parameters were the duration of tamponade, but primarily they were final visual acuity and complication rate. We looked at three main complications: uveitis, raised intraocular pressure requiring treatment, and emulsification of Denzeron. For some reason, the majority of the patients were males, as males don't get their fair share in most things in life, as you know. Mean age was 64. Most patients were phakic, and then there were a couple of aphakic patients. Now, majority of the patients were recurrent detachment who've had previous surgery, either with gas or oil. Now, looking at the PVR grades here, so interestingly, most patients either had no PVR or grade C PVR. I think most grade C PVRs were still posterior. Anterior PVR patients were very, very few. So let's look at the outcome. This was the table on your left is with Denzeron in situ at 2 weeks with oil in place. We had nearly 79.9% patients with retina reattached under oil. Now, as you can see, the results were better in recurrent detachments, but it was statistically not very significant. Likewise, after 3 months of oil removal, we had nearly 3/4 of patients attained retinal reattachment. The difference between the primary detachment and recurrent detachment was not statistically significant. Let's look at the primary outcomes by PVR grade. So total of 103 cases we had, the initial reattachment 107 and the final 96, and only 11 cases the Denzeron was not removed long term. And I'm aware of the concerns mentioned this morning about retinal toxicity, but perhaps there are other compounding factors relating to retinal issues with long-term Denzeron. Secondary outcome measures: best corrected visual acuity. Preoperative and postoperative, no statistically significant difference between pre and post-op vision. And as you would know, in cases like this, the objective is not to gain visual improvement, in fact, stabilize it or at least achieve retinal reattachment. Secondary outcome measures: anterior uveitis, 6% patients, raised intraocular pressure on treatment, 36% of patients, and emulsification was observed in nearly a tenth of these eyes. Interestingly, emulsification of 10%, most of these cases were only from one center, so we don't know what technique they were using. Median duration was 98 days. That's about over 3 months. So the question is, how do we compare with other heavy silicone oil studies? First of all, our study is the largest real-world study in the UK, published so far in the world. These are 3 previous studies you can see on your left, and we had the largest number. Retinal reattachment rates were very similar to other studies. Now, prior studies show reattachment from as low as 28% to as high as 86%. And it's different. The first RCT in 2011 recruited many grade C PVR eyes, and hence the reattachment rates were poor. If you look at the emulsification rates, variable, first study did not even look at that. So this is a comparison of heavy silicone oil versus standard silicone oil. Now, can I just have a show of hands that for inferior detachments, who is using just standard silicone oil and not Denzeron, including the patients with retinectomy? 5,000? 1,000? 2,000? Okay. 5,000. Okay. So it's interesting to see the comparison between a standard silicone oil and heavy silicone oil for inferior detachments. Again, 2 previously studies done, and our study had 134 cases. We had long-term pressure issues of nearly 12% eyes, a little bit higher in the previous studies, on standard silicone oil. So what is already known about Danceron is that yes, it is one of the agents used for to tamponade inferior detachments, and the anatomical success rate varies from 33% to 81%. We already know that, and the complication profile is already known. What has this study added? And by the way, our paper has been accepted for publication only in November, so you should be seeing it in press in the weeks to come. As I said, it's the largest real-world data, and it achieves a similar reattachment rates to conventional detachments. It has the same complication profile. There's no evidence that it is associated with higher complications compared with normal silicone oil. And the duration, interesting fact, emulsification and other complications were not associated with a longer duration tamponade. If they happen early enough in the study. We did not apply 360-degree prophylactic laser prior to oil removal, as done in some of the previous studies. Thank you.
Thank you very much. Our next speaker will be Dr. Hassanein Mohammed Bakhsh. He will introduce to us his speech about removal of drop intraocular lenses and scleral fixation of same IOL. Thank you.
Just please note, we'll have the question and answers at the end of the session.
And we want to restrict to the time, please, also.
Slides will be slipped. Okay, the case I'm going to discuss is the removal of dropped IOL, scleral fixation of the same IOL, and that particular patient had rhegmatogenous retinal detachment behind. So the history is that 58-year-old male presented to us with decrease of vein in his left eye for the last 3 months. The past history is that left eye was the only practically viable eye, and he had a trauma 20 years back to his right eye, as a result of which that eye was NPL. He had undergone cataract surgery in his left eye 6 months back. So he belongs to a poor socioeconomic status, teacher by occupation. On preoperative examination, he was having aphakic status of the lens with rhegmatogenous retinal detachment and grade PVR-C with dropped IOL. Well, this is the preoperative picture of my patient, and I just would like to show the video how we managed it. So our plan was to go for the pars plana vitrectomy and removal of the dropped IOL, scleral fixation of the same IOL, PVR peel and oil. Why this much exercise in this patient? Because this was the only eyed patient, and I had gone through the literature as IOL being the barrier for the oil from coming from the posterior segment into the anterior segment. So here is the video. So after inserting the ports, I started with the core vitrectomy. I'm showing the whole view of the lens. I was clearing the vitreous around the lens. The haptic of the lens had pierced the retina and it has gone underneath the retina. That was the point where the break was actually created. So after creating some space and clearing the vitreous around the IOL, I removed the haptic from underneath the retina with the help of in-gripping forceps and brought it into the anterior segment. As it was a rigid IOL and that patient had undergone extracapsular cataract extraction for the cataract, I have to reopen the same wound, brought the IOL out, So, giving a very small touch of Yamane's technique, I sutured both of the haptics with 6-0 Vicryl. And brought the edges of those 6-0 Vicryl out from the side ports. And fixed those sutures by cauterizing their ends. So it formed the bulb and stayed there. This was the final picture of the anterior segment. Then I went back in to address the big giant sitting over there. Peeling of the PVR membranes and vitreous was very difficult in this case. There were folds in which the inflammatory membranes had gone. So it took a lot of time. Patience was the key here. So I very gently, very patiently remove all those membranes, and after some exercise and some struggle, I had a view of disc and the macula. So after removing the membranes, I removed accessory membranes and the vitreous, peripheral vitreous. And the break, which was created by the haptic of the IOL, I trimmed the edges of that break because they were folded upon, and that is the nest of the PVR. So the important thing was the trimming of the edges of that particular break. Here I am trimming the edges of the break. So in the end, I did the air fluid exchange. Did the laser. Sorry for the view, the lens was foggy, that's why I tried to view the retina through very small space between the IOL optic and the iris. So I completed my laser, and in the end I filled it with the oil. So I examined the patient not on the first post-op day. I couldn't get this much VN. On the 7th post-op day, the best corrected VN acuity was with plus 5.5624. IOL was in place, slightly decentered superiorly, and retina attached with good silicone oil fill. This was the post-operative picture of my retina, and this was the anterior segment picture. Thank you very much.
Thank you very much, Stan, for such a lovely video in a very challenging case. Let me ask Mr. Muhammad Ali Haider.
So he's not here, sir.
He's not here. Asim Mahmood. Asim. Not here. Ali Zain. I think we have 3. Kashif. I think better you start. We have plenty of time to. I think we have all the time now.
Thank you very much. that was intraoperative OCT, but it's a new presentation. So the use of, I will just be sharing my experience with intraoperative OCT. It is a relatively newer modality, but we have been using it in our hospital in LRBT Lahore since 2-3 years. Sort of it came in COVID days, and we have, I mean, this is just what our experiences are. So you need a huge setup for this this sort of machine. I'll just revise this slide afterward and tell you that what I mean by that. So just a brief history. There were portable handheld probes to begin with, and then there were limitations because they increased the operating time, and they were very tedious, and they lacked the real-time imaging. Then the second generation, they were microscope mounted OCT devices. They were a little better, and one of the famous study, Pioneer 1, was based on those type of mounted devices. And now the third one which we have, these are the OCT and microscope optical systems are integrated. So they allow a real-time visualization of the instrument and interaction with head-up external view of the surgical field. So there are multiple, I mean, no financial interest, but the one which you are using is the Leica the microsystem with Enfocus. So, you know, you need a lot of space for those type of system, and you need trained staff. There is a lot of, you know, hustle around the theater when you're doing that type of thing. You can't do the surgery and capturing at the same time, clicking the mouses and everything. So you need a lot of staff as well as training of the staff as well. And it takes a little bit more, sort of 10-15 minutes now for extra time. One important thing was, you know, in the Leica system, they were incorporated this head into our microscope. So actually the distance of the surgeons from head to leg was sort of increased by introduction of this, and various surgeons use different techniques to decrease that. So it was a little tedious and had a learning curve to use that microscope. You can't take it off, it has to be there all the times. So we did a little bit of study to see how the use of intraoperative OCT is making any difference. And the most common condition we treated were detachment, and other conditions included diabetic vitreous hemorrhage and endophthalmitis and macular hole. And 16 patients were included in the study. And we will the cases were done by the same surgeon. And just to give you the example, in some of the cases in which the intraoperative OCT it caused a direct change in decision making. This is one of the case in which the OCT visualized a densely adherent vitreous, which on the it is looking very, you know, heavy, but on the operating microscope there was a little problem on visualizing this, so it would have been left. So in that particular case, IOCT definitely had an impact on the surgical decision making. So I'll just show you the video of that case at the. This was it. After removal, let me show you. And that was after removal of that membrane. So it really sort of affirmed the situation that there is no more vitreous left to be cleared. And then in cases of retinal detachment, the extra help which you can gain from IOCT is presence of any fluid, which is sometimes difficult. Sometimes you really have a cup of fluid left there, especially eyes which are highly myopic or posterior staphyloma eyes. There is always a doubt that going into the air, have you drained all of the fluid or not? And as in the previous slide, you have seen the presence of folds and everything. They are only due to when you leave behind those little bit of fluid, these folds do occur. So IOCT definitely has a role here to play in those type of cases. And in confirming the macular hole, I mean, as I explained in the previous morning session, there is no closure you have to see. You have to see other things, post-operative changes, intra-operative changes during the macro hole surgery, which are decrease in the overall diameter of the hole and the extension of the fluid here. These are the things you have to note. So just to give you a real-time picture of what intraoperative OCT, we were doing it in theater. And so its IOCT advantages are that it gives you a good visualization, and it some occult membrane, I mean, that 12% of the cases in some studies they were seen, and in some of the cases the surgeon thought there was complete removal of the membrane and peeling, but in 9% of the cases there was no membrane, so it avoided unnecessary further steps. And IOCT guided peeling has been described. So these are some of the problems we face in our daily practice in a public hospital. Patient comes, no record, surgery done 5 years ago. I don't know about other part of the world, but at least with our public sector hospital, this is the situation. You see at least 4 or 5 cases. The silicone is filled and giving you a high IOP. So what, in these type of cases, you go in and you find after clearing and everything and after removal of oil, you find a macular hole with no record available. So I mean, it is not necessary to prove it, but it gives you a little bit more confidence while doing the surgery. And in one of the cases, few of the cases you find after removal of the oil, you find an AMD scar. Okay, you can have that OCT done afterward as well, but at this time, the presence of scar, sometimes it is very difficult to drain the fluid over it after the detachment has settled. So IOCT definitely gives us some help in telling us that there is no fluid over there. And during very adherent PVD, this type of eyes, IOCT helps you. It tells us that there is a complete removal of the membrane and nothing is left. So these were the cases, these are detail of the cases, and we studied did the IOCT identify important structures, or did it alter surgical decision? And confirming surgeon's decision, yes, these questionnaires were answered after the surgery. And there were 16 patients, 100% acquired images were obtained, helped significantly modifying surgical decision in only 26%, sort of 27% of the cases, which was statistically significant. So these are the cases in which IOCT helped in making a change in surgeon's decision in doing some extra step or closing the case. So this was similar result was in one of the studies in which it was 30%. So there are limitations and there are small sample size, but it is still OCT, intraoperative OCT is a feasible and effective imaging device, and in future, especially in cases of macular grafting and macular hole flaps and everything, it does has a future. Thank you very much.
Thank you, Dr. Kashif. I would like to introduce Dr. Ali Zain, and he will talk about the efficacy and safety of PFCL at temporary tamponade in case of inferior retinal detachment.
Okay, Ji, I'm Dr. Ali Zain. Thank you very much for giving me the dice. I'm Assistant Professor of Ophthalmology in King Edward Medical University. My basic and primary talk was to use PFCL as a temporary tamponade for a period of 2 weeks to maximally 3 weeks in cases of inferior retinal detachment with massive breaks, grade B or grade C PVR. In few cases of grade C PVR and most of the cases of grade B PVR. Yes, please, next slide. I have to do it myself? Right. Basically, as you know, the tamponade is basically used to provide local surface tension to prevent the formation of or the leakage of fluid under the retina. That was the basic, and the permanent was to do the photocoagulation in cryopraxis. But the nightmare for every vitrectomy surgeon is the inferior retinal detachment. And inferior retinal detachment grade C PVR, or those patients which have got massive multiple retinal breaks or kind of giant retinal tears. Even if we do a very good surgery and we put oil in the patient or gas, patients are not very good in posturing, and most of the time there is a small cuff of fluid left right under the retina over the retinal breaks. That small space where there is fluid and you are not able to seal that space, small fluid, they start to percolate under the retina, and that is the thing which is causing the recurrent retinal detachment or inferior elevation at 6 months time. So my rationale was that instead of letting them unattended, letting them letting those small breaks free, we put a small cuff of PFCL temporarily till we do multiple sessions of argon laser and cryopexy and seal the inferior breaks, so that the recurrent retinal inferior elevation should not be seen after good vitrectomy. So, I mean, suppose this was a case which we have started, and it was a large hole and all. We did 23 gauge vitrectomy, core induction, PVT and all, shaving and draining, SRF, fair fluid exfoliation, endo laser, and then at the end we injected PFCL, and then we injected silicone oil. Basically, there were two bubbles. One was of silicone oil, and the other bubble was of PFCL, and that was actually to use as a temporary tamponade. So post-operative, this was the picture. This was the PFCL underly, and I mean, after that we did multiple sessions of lasers, and obviously the mainstay is the laser. We do a lot of lasers per-operatively, but after putting this PFCL, we made it sure that the inferior part of the retina is perfectly aligned and perfectly, and we have to see the safety and the efficacy. If there is any toxicity related with this PFCL, if we hold it more than 2 weeks or so, or if there is any chances of inferior retinal elevation post-operatively, that was what we intended to see. So barrage and all these barrages were done, and before to talk about the PFCL, some small talk about the PFCL. It has got high specific gravity, and instead of Densiron, if we put Densiron, it is very difficult to remove Densiron. Now, if you say that instead of putting the PFCL, why don't we put Densiron? I agree. I mean, Densiron is more safer, and you can put it for 3 months. But the thing is, heavy PFCL is a liquid. It is easy to remove. It gives a tamponade which you can do a very good working post-operatively, even if you, and there are chances of redetachment is almost, I mean, I haven't seen a single case in which there is a chance of inferior elevation after putting that during the time of temporary, and when we completed all the lasers and everything, the patient was very fine and healthy. The patient which I have shown you earlier in the list, and all 22 of those patients which we have injected, they were all having very good results. Basically, there are a few things which I have to see before that even if the patient is having a giant retinal tear, detachments, and the grade C PVR or grade P PVR, they were included basically in the study. And exclusion was, patient with mobile, grade A PVR was not included in the study. And so it's still ongoing studies. We have injected and we have seen the results in 36 of the patients. Most of the patients need to be AC wash. That is the thing. Most of this heavy liquid, they percolate from the posterior cavity and come into the anterior segment, and that is the thing which we got bothered about. We have to wash the AC multiple times. And second is that few of those bubbles, they can go into subretinal space. That is the thing which we, so these two things which has been seen, but once you can remove it methodically once you're done with the surgeries, and you have to remove the oil and you have to remove the PFCL along with it, and it gives an excellent retinal stability post-operatively. That's it. Thank you. Any question? Yeah. Question at the end? That means I've saved.
Thank you very much, Ali. Great presentation. Thank you very much. I think, yeah, we'll start from the top and then we'll go on to the questions. Do you want to ask anything to Ali?
Yeah, surely. Well, nice presentation. I'm a big fan of heavier stuff, as I say. But it's correct me if I'm wrong. So you put it temporarily, and then after 2 or 3 days, you take it out. 4 weeks. And then do you feel the necessity for putting gas in, or you just leave it? Then gas. Which gas do you use? Okay. I mean, yes, this technique has been done and published before. I just wondered, there is a concern of, well, firstly, its viscosity is not that great. It is expected to emulsify or break down smaller pieces which could get in under the retina, and you had that problem. Would you consider oil for 4 weeks and then just take it out? Then is it all for... Sorry, I have no financial interest, by the way. Yes.
All those cases which have got the inferior detachment. This whole case, this whole story is for the inferior detachments with multiple breaks, giant retinal tear, or even fenestrated retinas. I mean, the high myopia patient, they've got fenestrated retina, the whole of the inferior retina in the form of, there's multiple breaks. You do, but still there's a small cup of fluid which is left. Even if you do very good methodical shaving and everything, there's a bubble of oil when the patient is in spine position. You see that there's a cup of fluid, clear fluid, which is left at the end, and that fluid actually percolates through and goes into the retina. And patient is fine. Patient is going to see 6/6. He'll be seeing 6/6 for 6 months next. But there will be small elevation. Keep on coming elevation. Then the PVR sets in. That's a nightmare which I actually wanted to prevent.
Thank you. One question which may be to anyone presented on detachment, Usman, yourself. For multiple quadrant breaks, what posturing advice you give? Alternate side or something else?
Well, normally, initially, yes, it's the face down position, and then it's alternating right and left cheek to the pillow, and that goes on, depending what type of, predominantly the size and the locations of the breaks, but usually if they're equal on both sides, for first 48 hours, there's the face down, and then I do alternate cheek to the pillow for 1 week.
Same goes for inferior breaks. I just wondered whether supine posture may be the best for multiple quadrant breaks, because they all support, gas will support the anterior retina.
Absolutely.
My patients, normally patients, they don't, posture the way we try to make them understand.
Multiple breaks.
Yeah, I know. Can I just, I like Dr. Khurram to make a comment on this heavy liquid in the eye since we have the Densiron also. So what is the difference? Why we not be using?
About one comment about removal of the oil as opposed to heavy liquid. When I was using my first Densiron, at that time I had this fear that I will have to go back and so deep inside, and how will I get that dense oil out and everything. But after removal of my first heavy oil, it was the easiest thing, because you just have to engage the body of the oil and not to leave it. If you leave it, it will fall back, but as long as you don't leave it, it will keep on coming and it will just go away. Easier than the usual oil. So removal of heavy oil is not a problem. As far as, you see, the thing is, that fluid which we are talking about inferiorly, this is just to make the concept clear for everyone. The fluid we don't have to get rid of the fluid. You leave. How did cryobuckles work? Cryobuckles worked because all we had to do was close the hole. The fluid will go away itself. RPE is doing its job. So we have to cover the holes, and then, so rather than, okay, if you say that for socioeconomic reasons, Densiron cannot be made available for all these patients and you are making a makeshift, then obviously we cannot proceed any further on that. Because two things. Why do we need to do more laser? Are we not doing enough laser during the surgery? We should be doing enough. If we have to do 4 sessions after the surgery, that means we need to do more laser during the surgery. If you're not doing laser during the surgery because of lack of under laser or whatever, then again it's a different story. But you see, we have to give a message to everyone what is the ideal way and what
This is the second session?
So in those circumstances, perhaps, but I think we should do more laser. If inferior problems, do a big barrage.
This is the
Big
second. We have
barrage.
plenty of
Patient
time.
is not going to miss that.
We have half
upper
an hour
vision
to
field
close
which
this.
is already covered by the brow. Patient is going to look for the central vision. So big barrage
Yeah.
inferiorly, maybe not as much in the other areas, and it will work hopefully. Yeah.
Thank you very much, Dr. Khurram. Now, before we move on, I would just like to request Professor Dola, he's sitting at the back, Professor Jalil Dola sitting at the back. I need his pearls of wisdom from the times of scleral buckling. Now we have moved to vitrectomy, so we need to have few words from him, from Professor Jalil.
Thank you, Usman, for asking me for the comments. Frankly, I'm a buckler. I used to do cryobuckles when I was an active retinal surgeon. But since I left surgery for the last few years, I'm watching how the scene has changed. I've met and watched quite a few vitreoretinal surgeons operating on the microscopes with endo lasers and heavy. I feel still there is a place for buckle in these inferior retinal detachments. What you are doing,
you take over now.
With
Any
your
question, anything, add.
vitrectomy probe inside the eye, I think if you just place a 180-degree buckle below in time, I repeat, if you place this buckle in time, then it will kill the cat. And maybe you don't have to put Benseron and do a lot of laser. And I agree with Khurram that once you occlude the hole, the fluid under the retina will get absorbed. All you should do is occlude the hole one way or the other. I've forgotten there was a study from Israel way back. They would not put any cryo, they would not laser, they would just place a piece of silastic sponge, circumferential or radial, on the hole and make sure that the hole was closed and covered with a buckle. And if your buckle is covering the hole, the fluid will get absorbed. So I again repeat, I am experienced with cryobuckle and I have not much experience, but I keep talking to my son in Manchester, Asad Jalil. He doesn't believe, he did not believe in bucklings. He is a trained vitreoretinal surgeon and he will try to do things from inside. But last week, when I phoned him, he said, we are going to hold a course to teach cryobuckle, to teach the buckle. And 6 or 7 leading vitreoretinal surgeons of UK, they assembled last week. There were 15 people to learn, all at the level of senior registrars. And 11 big vitreoretinal surgeons were teaching cryobuckle. So the cryobuckle has its place. In a properly selected case, you do not need a lot of work inside. I say so because I've never done work inside.
Thank
The rest is up to you. Everybody has his own things. If I have a good experience of cryobuckle and I get something like 90% results with buckles, inferior detachments and buckles, I should practice that. And those who have not done buckles before, they should continue
Thank you very much.
Thank you very much for this very interesting. I am really from the era of scleral buckling. I am doing it every time, and I find it very simple, fun, cheap, especially for young adults. And I want to say that it is coming back. Scleral buckling is coming back, especially after the chandelier light assisted scleral buckling, which has been developing, and we are all, the world retina surgeon who is doing scleral buckling, now we are shifting to chandelier light assisted scleral buckling. It gives us a very nice results. We have also easy to teach it to our residents, who is not doing now indirect ophthalmoscope efficiently as we do. Thank you very much.
Thank you, Denisa, for sharing your pearls of wisdom. All the major studies in the last decade or two have not shown vitrectomy to be superior to buckles. That's true. And secondly, you would never regret doing a buckle. You will regret doing a vitrectomy on a young patient with macula on single break. It ends up into a total detachment PVR, and you end up losing the eye, because you can almost never lose an eye from a buckle.
Dr. Mahmood, you want to add?
Regarding the same thing, sir, yeah, cryobuckle I think is a piece of art. Vitrectomy is a thing, a technique which we do. It's just like going straight to phaco without having learned extra cap.
You do finish.
And at any time, one
Yeah,
could
we have
require
plenty of
extra
time.
cap. I have a question
Yeah,
for
yeah, now you
Dr.
talk.
Hasnain Baksh. Can I ask now? Huh? Is he here? So he's gone. So
who's?
Buckles ka, the issue with buckles is the training, because the so less and less numbers are being done. The consultants themselves haven't done enough to teach their fellows. In the UK training system, we have maybe 2 years, maybe 2.5 years of fellowship training, and if the fellow gets to do only 2 buckles, they're not confident enough. Logistically, yes, buckle takes longer. Vitrectomy, in the run-of-the-mill, yes, you can do 4 vitrectomies on a list, but buckles you can't do 4.
when I was in Ireland, actually, we were doing more buckles than vitrectomies, and whatever detachments we used to get, we used to keep on adding them on Friday afternoon, Friday afternoon, Friday afternoon. So we used to have 7 or 8 buckles, and at average time at that time, we got so well in doing buckles that we used to do in 20 minutes. So buckles can also be done in 20 minutes if you're spot on. But you need to keep doing that. So it's just practice. But
on first hand, you're always having an option for vitrectomy afterwards. Even if it fail, I mean, if there's inferior retinal detachment, we do buckle, right? That will give us support. Even if there's grade C PVR and there's a redetachment, that buckle will support us while we're doing the vitrectomy to give. We don't need to do the retectomy afterwards once we have the buckle in. If we are doing vitrectomy and we are trying to settle the inferior retina, that internal, that indent which has been given already by this buckle will help us to settle the retina more effectively. So that is always there. I am a buckle fan. That is for sure.
Okay. Dr. Mahmood, I'll be like your closing remarks now.
Thanks everyone for the wonderful session. Actually, before we end, I have one question for Dr. Osman. So in case of retinal detachment, total retinal detachment, and the main break is the macula, so there is a macular hole retinal detachment, how do you prefer to drain the subretinal fluid?
Well, obviously, I would avoid draining the fluid from the macular hole because of the obvious reasons. And I would certainly proceed with conventional vitrectomy and draining through the break, and then peeling the ILM under the heavy liquid. Because obviously, if the macula is detached, it's not easy to peel the ILM if it is detached stage. However, with under heavy liquid, it's easier. So I would just proceed as normal vitrectomy, draining through the break, peripheral break, not the macular hole.
The only break available is the macula.
I would then create a retinotomy. I would create a retinotomy and drain it from there rather than going through the hole.
I have a question to Dr. Hussein Baksh. Is he here? Hussein Bakhshi is not here?
No, he's left.
I could ask him about the material he is using to fix the lens. He said that by 60 Vicryl. I think other better materials will be actually very better, especially for young, because Vicryl will go disintegrated in a very short time. So what you prefer to do sometimes? Prefer to do? Vortex? Yeah.
No,
Vortex,
I think sorry?
Vortex. That's used by the cardiac surgeons. 70, I think it will be better. Although it is very flexible, it will be very difficult to insert in a syringe. But I think Vicryl is questionable.
Right. So thanks everyone for attending, and we conclude our session. Thanks everyone.
Thank
you.
you.
Very much. Thank you.
We have a picture together. Let us take a picture with the speaker. So,